Hello, and welcome to the second lecture for week 2. We will just get started on the laboratory values lecture and finish the rest of this in person next Wednesday. So this lecture is really important to kind of tie together things that are happening physiologically in the body to what we can actually measure and see, mainly in our blood products, and it gives us an idea of what's happening in the body. So I will try to keep this lecture very specific on, what you're looking for, how this being abnormal will impact your life as a PT. So you can see the objectives here. We're going to go through each specific lab value, their associated normative value, and then really put it in the context of, if you're doing a chart review, what is your decision-making process in terms of treating, understanding the clinical relevance of common lab values, and then because these are often used in the diagnosis of certain blood disorders, we will talk about some pathophys on some of the main blood disorders here. So when you're doing a chart review and looking at lab values, today we're going to go through the norms. And this is one of the few things in this class that I will tell you just have to memorize. You have to know the normative values for our lab values. It's critically important because you're part of a medical team and you need to be able to speak the language and be able to appreciate the significance if someone tells you something in the hallway. It's tempting in the age of electronic documentation because when you see lab values, it'll tell you, a little L for low or an H for high. And do I need to know what the cutoff values are? It really is important because if a nurse stops you in a hall and says that, I don't know if you should treat that patient, his hemoglobin, he had a bleed last night, his hemoglobin is 10. Well, you don't want to have to go look that up. You want to be able to talk to her right then and be like, that doesn't sound that bad. Like, what are his symptoms? Is he having any, shortness of breath? Have you tried to get him out of bed since that happened? You can have that conversation in real time. So I do think it's important. It's important to have a gut sense of what normal is. I promise I won't be a jerk on the test and ask you like 0.1 away from norm. I want you to have a gut sense of what these normative values are. Now, that being said, when you're looking at lab values, norms are important, but the most important thing is the trend that's happened with this patient over time. So the human body can adapt to many, many things if they happen slow enough. So an example is blood glucose levels. If you have a sudden change in your glucose levels, it can become life-threatening very quickly. An individual can have type 2 diabetes and very slowly, develop hyperglycemia. So like if you right now got plasma glucose levels above 200, you could end up, in a life-threatening emergency. You will see type 2 diabetics walking around with more than 500 mgs per deciliter, and they don't even notice. It happens so slowly. So that's an important thing to know when you're about to walk into a patient's room. If they had a sudden change in a value, even if it's not as dramatic, that might impact them a lot more than if, no, this is kind of their normal, like this is where they are, they're a little low for them, but this is in their range. Even though it's outside of the quote unquote normative range, it might not be as dramatic for that patient. You will see this a lot in our oncology patients where they can be running super low on their blood counts, but that might be kind of their normal. So even though it's far from the normative range, it could be within their norm. So it's really important to look at trends over time and to appreciate the acuity of the change. If any lab value had a sudden change, you would expect a more dramatic clinical presentation than if it was a slower change over time. So it's just something to kind of keep in the back of your mind, and I'll say it a bunch of times this lecture, but the trends are the most important. And when you start doing chart reviews, and we'll go through some cases, We'll be looking and thinking about that trend. Okay, so for each of the lab values, we'll look at kind of some different series of tests that can run. And the first is a complete blood count. Complete blood count typically will give you their hemoglobin and hematocrit, red blood cell, white blood cell count, and their platelet count. So let's go through each of these and kind of think about them in the context of clinical medicine. So the first is hemoglobin, which we already kind of talked about in our little shout out to the red blood cell at the beginning of the acute inflammatory lecture. Obviously, hemoglobin is the oxygen carrying protein of the red blood cell. It is an iron-based protein, so it is dependent on iron to have normal hemoglobin. The normative lab values are listed here. Women typically have a little bit less than men, but that is what you'd expect for normal oxygen carrying in the blood. So we're learning about lab values in terms of are they outside of the normal range? What would it mean to this patient if their hemoglobin is low? Hopefully, what comes to mind is they're not going to be as good at delivering oxygen to the body. Okay, what does that mean? Like, what is the significance? If they're not as good at delivering oxygen to the body, does that have any effect on the heart? Well, the heart is going to have to work harder. It's going to have to pump more blood because the blood that it's pumping doesn't have as much oxygen in it. So if someone has low hemoglobin, you might expect them to have some elevation in their resting vitals, like a higher than normal heart rate. You would expect, if they're having a worse ability to deliver oxygen to their body, that these patients might not have a great endurance, right? They might get more dyspneic. They might have a difficult time participating in physical therapy or activity that maybe shouldn't be exhausting, might be very difficult for them to do because they can't deliver the oxygen that fuels, the metabolism of the body. So if hemoglobin is low, this little number in a chart, it gives you a lot of really important clinical information. It lets you be alert to things you should watch for. Okay, so if you have lower than normal oxygen delivery and you have a heart that's working harder than normal, let's put those together. Could they actually have less oxygen being delivered to a heart that's working harder? So one of the things that you want to watch for, especially if they have cardiovascular risk factors, is signs of angina. That's chest pain related to ischemia. So when hemoglobin gets less than 9 grams per deciliter, patients become at much higher risk of having angina symptoms. Because their hemoglobin is so low, they can't deliver the oxygen to the heart that's making up for the difference. These concepts will get reinforced. If you're feeling a little bit like, whoa, that was a lot, we'll reinforce these. Stay with me. Just trying to tie a simple lab value to a larger clinical presentation. So take it all the way to the end. Red blood cells carry oxygen. Oxygen is necessary for cellular function. Without it, we'll have to deliver more. How do we deliver it? The heart. What's going to happen to tissues? They're still not going to be getting enough oxygen. They're probably not going to be doing their jobs as well. Kind of following that through. The second value that often gets reported together is hematocrit. So we often talk about H and H, hemoglobin and hematocrit. Hematocrit is the ratio of packed red blood cells to the whole blood. Kind of like saying what percentage of blood is the cells. So hematocrit can be a little bit more helpful to assess blood loss and fluid balance. For our purposes as PTs, hemoglobin and hematocrit normally track together. So if one is low, they're typically both low. We don't normally get into the kind of intricacies of what hematocrit might get you. So it really carries the same story as hemoglobin. If hematocrit is low, you would expect worse oxygen carrying. All right, so let's look at kind of the changes to these two again. So I kind of jumped into if hemoglobin is low. but there is a chance they could be high. So when hemoglobin and hematocrit are elevated, it's called polycythemia, elevated hemoglobin and hematocrit. And the clinical cutoff is when it's greater than 20 grams per deciliter. Now, in general, it'd be very unlikely that polycythemia would be a reason that you wouldn't treat someone. So it says in your notes, the blood is more concentrated. There's a chance that you could get some clogging of capillaries because there's so many cells to volume. But in general, it's rarely a stop to treatment. So if you're worried about, can I treat someone who's polycythemic? It's like you do a symptom-based approach. Like, are they having symptoms related to this that's actually causing something clinically relevant? You talk to the medical team and you might make a decision. But in general, having higher than normal red blood cells isn't going to be real critical to therapy. When they're low, that's when we're talking about anemias. So anemias are reduced hemoglobin and hematocrit. I'm going to go back a page just for a second for numbers. So we don't really have cutoff numbers for hemoglobin and hematocrit anymore, but I like to give you an old trick that we used to have. It's not really true anymore, but it kind of gives you a threshold for the low. So historically, it used to be that patients would be getting a blood transfusion when hemoglobin and hematocrit were at 8 and 24. 8 and 24 was like this magic number for hemoglobin and hematocrit. And it was kind of low enough that patients needed to get blood transfusions. Now, fast forward to modern day, we have kind of learned some of the perils of lots of blood transfusions, and we've kind of learned to trust a symptom-based approach, and they're doing less blood transfusions. So it's no longer true that it's like a blanket rule that at 8 and 24 they get transfused. But if it helps you kind of know when you're in the scary danger zone, I find myself, because I'm old school and I existed in a world when this was when blood transfusions happen, but it gives me a sense of where the floor is, if that makes sense. Like 8 and 24, back in the day they used to transfuse them. Now I might be treating them, but I am in the low land, and I need to be very aware of the consequences that come with that. Okay, let's go through kind of what might cause this, and that might help us make some clinical determinations of our patients. It also just gives us a chance to talk about all the forms of anemia here in class. All right, so causes of anemia. The first one's probably the most straightforward. It's from blood loss. If an individual has a bleed, the blood cells will leave their body and they won't be there anymore. So you can regenerate those cells, but that growth, differentiation, and maturation from the bone marrow will take time. So after someone has had a bleed, their hemoglobin and hematocrit can be very low. So you will see this, post-surgical. If it's very low, you want to go to the surgical report and be like, what happened here? If someone has had a trauma, they're going to have had blood loss, and that blood has left their body and they don't get those cells anymore. So if they do lab work, it will appear that it's low. So it's not necessarily that there's something pathologically wrong with their ability to create cells. They might have just, lost them on the sidewalk, and now they have to give their body the time to grow new red blood cells. So blood loss is probably the most straightforward. The next one on the list is reduced erythropoiesis. So that's reduced ability to make red blood cells. So if we look at the specific types of diseases that result in reduced erythropoiesis, we'll see that if we don't have enough nutrients to make the cells, we won't have enough hemoglobin hematocrit. So iron is a really big one. Folic acid, vitamin B12 are necessary elements of the development of red blood cells. You can see if there is a failure in the bone marrow to make red blood cells. So aplastic anemia is damage to stem cells within the bone marrow, so then they can't make new red blood cells. There is an anemia of chronic disease, that when you have chronic systemic inflammation, it can reduce the growth of new blood vessels. And then when the bone marrow has been infiltrated by, something like a tumor or inflammatory cells. Basically, the bone marrow that should be this, wonderful environment to grow new cells is replaced by fibrosis or tumors or granulomas. So then it cannot make the red blood cells. And then the third one on the list is hemolytic anemia. In hemolytic anemia, you are able to make red blood cells, right? Your bone marrow is working fine, but your body is destroying the red blood cells. It's breaking them down faster than they should, and so you don't have enough. So there is a whole host of hemolytic anemias. Don't memorize this list, but it can be helpful to know that there's many, many forms of this. We are going to just focus in and talk about one that is extremely common, which is sickle cell anemia. Sickle cell anemia falls into the category of hemolytic anemia. It is a genetic condition that's present at birth, and it really exists in a mutation of their hemoglobin. So most of the hemoglobin in our red blood cells is called hemoglobin A, and it has 2 beta chains and 2 alpha chains. In sickle cell anemia, in this genetic condition, the hemoglobin is called hemoglobin S for sickled hemoglobin. And it has the beta chains are mutated. So this is where the genetic mutation has caused a problem, is in the beta chains. Now, the effect of having these mutated beta chains is when there isn't an oxygen bound to them, they actually like to polymerase. Polymerization is just kind of a fancy name for they make really long chains of hemoglobin. So let's look at what this looks like in the cell. And I kind of titled the cell like, how does it sickle? What does that mean exactly? So in a oxygenated state here on the left side, when oxygen is bound to the hemoglobin, all of the binding kind of keeps the hemoglobin molecules separated from each other, and that creates the internal environment to create that biconcave disc of a red blood cell. When the beta chains do not have an oxygen molecule bound to them, they like to polymerize or form these long chains. When the hemoglobin all link up in these long chains, it actually creates this sickled shape of the red blood cell. So it talks in your notes about reversible sickling and irreversible sickling. So in the beginning of this red blood cell's life, it has the ability to reversibly sickle. Basically, it can go back and forth between these two. It can become deoxygenated and sickle, get exposed to oxygen, and it can go back to normal. The problem is, after many cycles of sickling, the membrane ultimately gets damaged. And at that point, the red blood cell becomes irreversibly sickled. It's basically stuck in this shape. So if you look at a blood smear that includes sickle cell anemia, you can clearly see, the sickled shaped cells, the beautiful concave discs of a normal looking red blood cell, and then the flattened, kind of squished, sickled red blood cell. So individuals are born with this condition. They typically start having symptoms at around 5 months of age. The reason that this is a cause of anemia, because you might say, well, they don't look normal, but they have, they're making red blood cells. The reason this is a cause of anemia is because the irreversibly sickled cells get marked for destruction. Remember, this is a hemolytic anemia. They're making the cells, but they're getting destroyed too quickly. A normal red blood cell lives for 120 days. That's the lifespan of a red blood cell. We get it for about 3 months. The lifespan of a sickled red blood cell is around 20 days. So if you're making red blood cells at a healthy, normal rate, but you're killing them much quicker than normal, you will deplete your red blood cells. The red blood cells have such a short lifespan of only 20 days. One, because they get marked for destruction. So they have hemolysis and they undergo phagocytosis because of the damaging. But they also, because of their sickled shape, end up getting trapped in the spleen. So they can get stuck in the spleen because they can get in, but they can't get out with their odd shape. So you will definitely see, treat individuals with sickle cell anemia. A fun fact about sickle cell anemia, if you're into kind of genetics, is there's an increased likelihood of having this genetic trait in people living in Africa. And it is a protected gene mutation because if you have a single mutated beta chain, not a double, but if you have a single mutation, it actually improves your tolerance against malaria. So in an area in the world that experiences more malaria, this is a protective genetic mutation because it actually increases the likelihood of survival to that condition. So it's very interesting, and it can kind of help explain such a high prevalence of this condition. There really is no cure for sickle cell anemia. It's a genetic abnormality. So really the only cure is a bone marrow transplant to replace the bone marrow. So that's just one example of hemolytic anemia. But regardless of the cause, whether it's blood loss, reduced erythropoiesis, or a hemolytic or a destruction kind of anemia, the signs and symptoms of anemia are shared. And we'll kind of talk about some differences between. The first is that individuals who are anemic experience fatigue and lethargy. And that is because they have a reduced ability to meet the oxygen demands of their body. If you can't carry enough oxygen in your blood, you are going to feel fatigued. And so individuals who are anemic, that's something that they struggle with. The next common sign and symptom associated with anemia is splenomegaly. Splenomegaly is an enlargement of the spleen. I put the picture kind of showing where it is because it's kind of this like tucked away little hidden organ in kind of the far upper left abdomen. Now, the job of the spleen is that it gets rid of old, damaged, or deformed red blood cells. It's also kind of like a big lymph node. The spleen stores a lot of platelets and white blood cells. So the spleen can get enlarged because if its job is to get rid of old and damaged red blood cells, sometimes these damaged cells can get stuck in the spleen. So this is the picture of like the splenic sinusoids. They're these really small, irregularly shaped blood vessels that the red blood cells have to kind of like squeeze their way through to get out of the spleen. And so when they're damaged and misshaped, they can get stuck in the spleen, and the spleen accumulates red blood cells and it gets enlarged, and it can actually become palpable as evidence of an anemia. Another common sign and symptom of anemia is jaundice. So jaundice is a yellowing of the skin and connective tissues. It's most prevalent like in the whites of the eyes. And the source of the color is too much bilirubin in your blood, in your body. So a red blood cell lives for 120 days normally. When you break that red blood cell down, you have to get rid of the hemoglobin. And bilirubin is the end product of heme degradation. So as the red blood cells are going through their life cycle and they die off, one of the end products is bilirubin. Now, the liver converts bilirubin into a soluble form, and it's excreted in the urine and the feces. Okay, so this is when things are functioning normally. We normally break it down, we make bilirubin. The liver allows us to create a soluble version of bilirubin that can leave in the feces and the urine. If you have a hemolytic anemia and you are breaking down more red blood cells than normal, you can overwhelm the liver. And the liver can't keep up, conjugating enough bilirubin. and the bilirubin collects in the connective tissue. Bilirubin has this yellowish color, so it creates a yellowness of the skin, areas of the mouth, a whiteness of the eyes becomes yellow. Another clinical evidence of a hemolytic anemia is gallstones. So some of the bilirubin is used to make bile. When you're breaking down all these extra red blood cells, you end up with stones being formed in the gallbladder with increased bile. And the type of gallstone is known as a pigment stone. It's like black in color, which is evidence of this increased bilirubin. So these are some outwardly kind of facing physical symptoms of anemia. They can also do additional laboratory tests beyond just what's your hemoglobin and hematocrit to determine if an individual is anemic and kind of the cause of their anemia. The first is a peripheral blood smear. So on the left, you can see a normal slide. On the right, you can see an anemic slide. It clearly has fewer cells, but they go beyond that and they really look at what the cells look like. Like they can describe what they see here. They can have microcytic. Microcytic cells are abnormally small. They can have macrocytic. Oh, and I realized that I'm drawing on the slide. Normally I just write these on the whiteboard. I'm not pointing to individual cells here. I'm just saying they could see these findings. They could also have, I'll just put on the bottom now that I just did that disclaimer. They might see normocytic, meaning normal sized cells, but with abnormal shapes, where the shape of the cell is abnormal. So this can all be diagnosed by actually looking at it under a microscope. Another test they can do is the reticulocyte count. So a reticulocyte is an immature red blood cell. It's a baby blood cell. So red blood cells are made in the bone marrow, and they are released as reticulocytes, and they circulate for about 1 to 2 days before they develop into a grown-up, mature red blood cell. So reticulocytes are baby blood cells that float around for a day or two. They can look at how many reticulocytes are in the blood, and it can be an evidence of anemia when you're having increased red blood cell breakdown. You might compensate for that. So you will stimulate red blood cell growth, which means that you would expect higher than normal reticulocyte count. So if you're having a hemolytic anemia, the body will try to make up for the loss by increasing the production of new red blood cells. So more baby blood cells than normal will be in the cell as evidence of a compensation for a hemolytic anemia. If you have an anemia of reduced erythropoiesis, you'd expect a lower than normal reticulocyte count because the bone marrow is the problem. It's not making the red blood cells in the first place. Let's follow this clinical evidence through and see if we can apply it to the one anemia we really went into a lot of detail about, which was sickle cell anemia. So this first question should be sort of a gimme. What type of anemia is sickle cell anemia? So we said anemia can be anemia of blood loss, reduced erythropoiesis, or hemolytic anemia. So what type of anemia are we having? It's a hemolytic anemia. The sickling marks the cells for destruction, and the cells are dying right after only 20 days as opposed to 120 days, which is creating the anemia. Okay, so we're breaking the cells down too quickly. Do we expect elevated, normal, or low erythropoietin? Now, just as a little fizz reminder, erythropoietin is the hormone that's released by the kidney. So if you have low oxygen content in the kidney, it will release erythropoietin and it will stimulate red blood cell production. So in hemolytic anemia, would you expect the kidney to be releasing the hormone that would stimulate red blood cell growth? Do you think this hormone would be higher than normal, unaffected in a normal level, or lower than normal? If you're breaking the cells down, your body's going to try to compensate by making even more cells, and that signal is erythropoietin, so I would expect elevated erythropoietin. What about blood reticulocytes, the baby blood cells? In sickle cell anemia, do you expect them to be higher than normal, normal, or lower than normal? They are elevated, right? Because the erythropoietin is telling the bone marrow to make more cells. So you're actually pumping out more cells at a faster rate. So you would see more baby cells in the blood than in a normal situation. What about bilirubin levels, that yellowing color? Is that going to be higher or lower or normal if you're breaking red blood cells down quicker? Elevated, right? Because that's where the bilirubin is coming from breaking down all the red blood cells and that final breakdown product of heme. Nice. What about anemias of diminished erythropoiesis? How does this change? I encourage you to write down your answers to this. What do you think would happen to erythropoietin levels, and what do you think would happen to reticulocytes? You can just hit pause on the video and write down your hypothesis. It'll help you know if you've got this stuff down, and it'll make it easier when you come to study it later. All right, so for erythropoietin, hopefully you paused and unpaused at this point, what would you expect? Well, the problem's in the bone marrow is not making enough red blood cells or unable to make red blood cells. What is the kidney experiencing? The kidney is experiencing the anemic cells, so it's experiencing hypoxia. If the kidney is experiencing hypoxia, I would expect increased erythropoietin, right? More hormone going to the bone marrow, but the hormone isn't effective because the bone marrow is the problem. And then what about reticulocytes? Are there more, less, or normal numbers of baby red blood cells? They can't make cells. So I would expect reticular cell count to be low. So it's helpful to see how these laboratory measures can help elucidate what is the source of the anemia if it wasn't immediately obvious. Okay, that was a rather long aside for our first lab value of hemoglobin and hematocrit. Let's talk about our next one, which is white blood cells. We're going to return to this figure when we talk about certain blood cancers, but this just shows the natural development of our blood cells. Right in the bone marrow, it all starts as a stem cell. And if you're not familiar, a stem cell is like a cell that doesn't yet know who or what it will be. It's kind of neutral, and it gets signals internally and externally to change and develop organelles and structure that makes it develop its structure and function in order on the path to becoming a mature cell. So in the bone marrow, stem cells divide and become either myeloid or lymphoid stem cells. Then they further progress to what's called a blast cell. And then from there, they take on the characteristics of the final adult cell. So the blast cells will go on to become red blood cells and platelets. And then two of our main white blood cells. In this chart, they kind of lump together a number of white blood cells into granulocytes, but granulocytes are any of the white blood cells that have small granules in them. So this is neutrophils, eosinophils, basophils, all kind of fall into this granulocyte. So this is actually where our neutrophils would live, as well as basophils and eosinophils. The myeloid blast cell can differentiate into a monocyte, and then the lymphoid stem cells are what gives rise to our lymphocytes. The laboratory work that would measure white blood cells will give you a count of the number of mature white blood cells per microliter of blood. And it's important to know and think about the function of a white blood cell when we're interpreting a laboratory value here. So the normal range is 5 to 10,000 white blood cells per microliter of blood. And this is the normal circulating levels when the body has a healthy immune system. It is capable of defending itself should it be invaded, but it certainly doesn't appear to be invaded right now, right? It's kind of in a resting state. When you see leukocytosis, that is the term for an elevated white blood cell. And it basically elevated, you get the term leukocytosis as soon as you cross that 11,000 cells per microliter threshold. When you see higher than normal white blood cells, what that should kind of signal to you normally is that your body is fighting something. Your body is raising up white blood cells. It's recruiting soldiers to the scene because it's trying to fight something off. So elevated white blood cells can be a sign of an infection. If you look in your notes, I have some common causes. So infection is number one. They can be elevated when you're fighting a cancer, after trauma. Smoking can cause just chronic elevations. All kind of reasons, but when they're elevated, you're thinking about your body fighting something. You do not need to memorize the symptoms that are listed in your lab notebook. A lot of these are symptoms that kind of go with the causes. So it's not necessarily a direct effect of the white blood cell count, but what you often see when it's elevated. The one thing I just want to mention is the fever. And if somebody has elevated white blood cells, that's increased likelihood that they're fighting an infection. If they have a fever, that can be a clinical reason that you might not treat that patient, depending on how acute it is, how high it is, what the treatment plan is for that patient. But that raises the level of alarm if there is elevated white blood cell count and fever. Leukopenia, on the other hand, is when you have fewer than normal white blood cells. Now, this is a case that tells you that this person might be unable to fight an infection. This is a vulnerable population because if they get exposed to something, they might not have enough white blood cells to fight it off. So when white blood cells are high, it's evidence that they're currently fighting something. When white blood cells are low, it makes them vulnerable that they might not be able to fight something. So the most common population we see this in is our oncology patients. This is a side effect of chemotherapy, so it's a regular occurrence in oncology. Again, do not memorize the symptoms of low white blood cell count, but it again raises the alarm if a patient has a fever, because if they're already at a weakened state and an evidence of a fever would be a reason that you might not treat them. So the names leukocytosis and leukopenia have these distinct cutoff points, but what your decision to treat is going to be completely a symptom-based approach. So there used to be, when I first started teaching this class, there were cutoffs for everything, like the number to do resistance training, the number to do aerobic training, which was, worse for students because they had to memorize a lot more for this lecture. But sometimes it can feel a little scary to not have that guide. But this will give you freedom to use your clinical judgment, and you will be able to provide better care that the recommendation now says to use a symptom-based approach. Talk to the medical team and gauge the level of safety for that patient. Again, and I just kind of put it on this slide, the caution around this decision-making gets enhanced when there is a fever. And I just wanted to give you the cutoff for neutropenia. Neutropenia is kind of a significant reduction in white blood cells. So when you're less than 1,500 per microliter, and these patients can be treated with proper precautions, but they will often require what's called neutropenic precautions. And I just wanted to put it on your radar what that is. Every institution might be slightly different, but in general, you are at the heightened level of protecting the patient from getting anything possibly invading their body. So, you wash your hands, which we do anyway, but that one's on there. You do not treat these patients if you feel ill at all. Like, you just absolutely will not go in their room if you don't feel well. They don't have any fresh flowers or plants because of the fungi that could be in them. They will not be served uncooked food. Nothing like no fresh uncooked food will be allowed in the room. It gets, they trying to protect anything that the body might have to fight against. All right, the next value in the complete blood count is platelets. So platelets are actually little cell fragments. They don't have a nucleus. They live for about 10 days, but they're really important in initiating the clotting sequence. So you want to have a sufficient number of platelets so that if you start to bleed, you can form a blood clot. That's really kind of the end all be all here. If you have too many platelets, thrombocytosis, and you're above 450,000 per microliter, the risk here is that you might be forming clots by accident, I guess is the best way to put it. Thrombus, they're clots that aren't supposed to be there. When platelets get too high, there's an increased risk of clotting, venous thromboembolism, VTE. The most common cause of elevated platelets is malignancy or cancers. So this is a pretty big red flag if this is found. The likelihood of an unprovoked venous thromboembolism is so unlikely in a healthy population that it can trigger the series of events that would lead to kind of searching out and searching for the cancer, because they're so common that it's such a common cause. So then the opposite, thrombocytopenia, is when you have reduced platelets. So if you don't have enough of them, then you won't be able to clot when you need to. So patients with thrombocytopenia have increased risk of bleeding. Now on the slide, it says fall risk awareness. The reason we care so much about falls when someone has a risk for bleeding, obviously we don't want patients to bleed ever, right? Bleeding is not good. But if they fall down and they cut their hand and it takes longer for the bleeding to stop, that is inconvenient but not terrible. The problem is that if they fall and hit their head and they don't have enough platelets to clot, they can get a bleed in the head. And this is really scary because your brain is in an enclosed space in the cranium, and it can very quickly turn into a much bigger problem and cause a stroke. And so we take extreme caution when someone is at a bleed risk to make sure that we're doing mobility in a way that we don't put them at a risk for fall. So do you treat? Do you not treat? If they have too many platelets, movement is good, right? Mobility is preventative of venothromboembolism. So mobility is good. If it is too low, then you have to think through their fall risk and make sure you're making a safe choice and not putting them at risk for falls. So I kind of put that in all caps in your notes under clinical issues of risk of bleeding. Obviously, you might see evidence of bleeding. Here's an evidence where you can see some additional bleeding. There's other clinical signs, including petechiae, which are these little small, these are like 1 to 2 millimeter kind of red purple spots. They're evidence of broken capillaries. So you can see petechiae form if there's things that might suddenly increase pressure. So sometimes if a patient has like a coughing fit, or if they're vomiting, that can increase their pressure suddenly. On extreme cases, PT mobilization raises pressure and can actually have petechiae kind of develop. The third clinical evidence is ecchymosis, or bleeding under the skin, where you can see that evidence that they have had frequent bleeds. Just as a clarification on terms, earlier we had talked about hematoma when I was trying to really say lots and lots of times that red blood cells don't leave the capillary during acute inflammation. I said if it does get out, it's a hematoma. So the term hematoma is for bleeding outside of a blood vessel. It's typically caused ecchymosis when it's a hematoma of the skin that's greater than 10 millimeters. So this is like kind of a significant bruise, can get the name ecchymosis. Okay, so I had suggested that I ignored one important step in vascular homeostasis after an injury, and that was by largely kind of blowing past the hemostasis phase of injury. And hemostasis is the process of trying to stop the bleed. and it's critically important as part of the vascular response to injury. So let's talk about it here. So when an injury happens, the first response is to have a vasoconstriction. And that is from local production of norepinephrine and a hormone called endothelin get immediately released, and the blood vessel shrinks. That would help prevent a bleed in that moment. The second response to injury is blood clotting. The process by which we make a blood clot first involves platelets. So here you can see that resting platelets kind of have a, I want to say calm outer edge, like a smooth outer shape. And in response to an injury, we activate platelets, and they kind of get this spiky grabbers that allows them to aggregate and actually form a platelet plug. So with blood clotting, the overall goal is to first plug the hole as fast as possible. So a platelet plug is when you jam a bunch of platelets together and it kind of like fills the hole where the bleeding was happening. The secondary goal, or secondary hemostasis, is to make that plug strong so it stays in place and will form a full and kind of mature clot. So let's go through the steps of primary hemostasis. And I know I have like step 1, 2, 3 written in your notes, but then there's space in the bottom to draw. So come with me and we'll draw together the process of primary hemostasis. All right, let's first set the stage. So we have a blood vessel. And I'm going to draw the endothelial cell layer. But we're talking about a vascular injury. We're not necessarily just in a capillary bed, right? Like you can rip through small arterioles and get a more significant injury. So I'm going to add the basement membrane. I'll label it for you. So we've got basement membrane here. And then the outer wall of the blood vessel. Let's close it all in. So we're dealing with a little bit more structure. All right, what's floating by? Obviously, we've got some red blood cells in here. So let's add those guys. We've got red blood cells. We have floating in the blood inactivated platelets. So I'm going to draw that as a circle with two surface glycoproteins. So an inactivated protein on its surface, you can see glycoprotein 1b. So this little Y guy is going to be glycoprotein 1b. And the other glycoprotein I'll try to draw differently, like a little square, is glycoprotein 2b3a. And this is going to be kind of hidden in the inactive state. And then floating in our blood, I'm just going to draw them as green circles, and those will be our clotting factors. So let me add some clotting factors to our blood and some inactivated platelets. They've got their nice round surface. 1b, 1b, and then tucked inside the 2b3a. So at this point, blood is flowing. There's no injury, but we've got stuff in our blood that can make a clot all the time. So I guess the first question that's important to ask is, what prevents a clot from forming normally? If all this stuff is floating around, why don't they just form clots all over the place? And the first answer to that comes from the endothelial cells, that inner layer of cells. The endothelial cells release important vasoactive substances when they are healthy. So the two, let me see, all right, endothelium. Endothelium releases nitric oxide and prostacyclin. A happy, healthy endothelium will be kind of constitutively producing nitric oxide and prostacyclin. Nitric oxide and prostacyclin vasodilate the vessel, they help to keep it open, and they prevent platelet adhesion to the endothelium. So the abbreviation for nitric oxide is NO, which I find handy because I picture the endothelial cells being like, nope, no, nope, can't stick here, nope, can't stick here, nope, 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 nope. That's what the endothelial's job is it protects the walls of the blood vessels and it doesn't let anything adhere. Prostacyclin does it as well, but it doesn't abbreviate to no, so I only include that in my picture. All right, so a healthy endothelium prevents the platelet from adhering to the endothelial cell. The other thing that's really important is that we've got blood flow going through this tube, right? And it's going pretty quick. We are flowing through this tube in laminar flow. And with blood flow happening, the second answer to why don't we form a clot all the time, answer number one being the endothelium protects us and prevents it. And number two answer to that question is normal blood flow continues to wash out these clotting factors. If blood is allowed to slow down and clotting factors have a chance to kind of bump into each other and bang around, they actually can spontaneously develop a clot. So I mentioned this at the front end before we talk about clot formation to first kind of factor in why doesn't it always happen? Because we are going to talk about cases where people develop clots inappropriately, and it's typically from either some damage to the endothelium or a prevention in the ability to wash out clotting factors. And we'll see this come back again and again. All right, let's give our blood vessel an injury. Let's induce a vascular injury. You can either, if it was my paper notes, I would redraw this blood vessel again. So if you want to pause the video and redraw the blood vessel, I'm going to give it an injury kind of right here at the bottom. So you might want one picture of a blood vessel that shows how we prevent clots, and a second picture of a blood vessel that has the injury. If you don't, you can just add it to it. I think you can add to the picture, but that might be something that I would do. All right, so we've had vascular injury. So let's break through the whole wall. We've ripped it open. So with vascular injury, the first thing that you'll notice is we've just ripped through endothelial cells. So at the site of injury, we are going to have, basically no nitric oxide or prostacyclin. Those two vasoactive elements that normally keep elements away from them are gone because we just destroyed the cells that made them. The second thing that happens is when you take away the endothelial cells, you reveal the subendothelial materials. And these are materials that are in the wall of the vessel that should not be exposed to blood elements. One very important one is von Willebrand factor. So I'm going to draw it in as like little triangles here. So this is von Willebrand factor. And von Willebrand factor is a blood glycoprotein. Its main function in life is to bind other proteins. So it's got a really important job right underneath those endothelials normally. In the subendothelial region, it actually binds the endothelial cells to the collagen of the outer wall. So it kind of helps hold the wall together. So von Willebrand factor's job is binding cells together. So that's all well and good, except we just ripped the cover off of it and exposed it to the elements. So von Willebrand factor is exposed. We've got collagen exposed. So what's important here, right, is that von Willebrand factor is, maybe my picture could be a little better, is bound to the collagen, but it's exposed to the blood elements. So at this point, if you noticed in my drawing, I made the shape of von Willebrand factor the exact shape of our glycoprotein 1b. So with von Willebrand factor exposed, it binds to the 1b receptor on the platelet. So let's put these two together. So it binds the 1b receptor. When a platelet gets its 1b receptor bound, that is the phase of adhesion. And as soon as it binds, this causes platelet activation. So let's draw it on. The exposure of von Willebrand factor binds the glycoprotein 1b. Now, instead of a nice circular platelet, we've got this spiky, crazy activated platelet, and the 2b1a is now flipped to the outside. So platelet activation allows the platelet to change its shape. It went from smooth to spiky. It exposes the 2b3a receptor. It got flipped to the outside. The 2b3a receptor has the ability to bind to fibrinogen. So let me get rid of some of my laminar flow picture here so that it's not so messy. We'll just redraw that guy quick. Looked a little messy for my liking. All right, so here is the 1b with an activated platelet, which now has 2b3a on the outside. And 2b3a has the ability to bind to fibrinogen, which when the platelet becomes activated, it also releases fibrinogen. Fibrinogen is kind of like a little string. So if we have one platelet here, we definitely have another, right? Because they're all floating by. So we've got another platelet activated with the 2b3a exposed. And the 2b3a receptor binds to fibrinogen. The 2b3a receptor binds to fibrinogen. So you get to tie a little string between these two. They're bound together. You've formed a bridge between platelets. So if we kind of review where we came from, in normal blood, inactivated platelets are floating by. The injury exposed von Willebrand factor, which has the ability to bind the 1b receptor on the surface of an inactivated platelet. The binding of the 1b receptor activates the platelet. Platelet activation changes its shape, flips the 2b3a to the outside of the platelet, and releases fibrinogen. Floating around fibrinogen is going to be grabbed onto by the 2b3a, and now we've got strings tying the platelets together. The next piece of this is that when the platelet got activated, it released factors into this local area that cause further platelet activation, and it promotes aggregation. So the platelets that actually floated right by von Willebrand factor got activated, but you can see, let me kind of make this, you can see this guy right here, he's just floating by, he hasn't been activated. This guy right here hasn't been activated. So we have to be able to activate additional platelets to get this plug. We want a lot of them. And platelet activation actually does this. It causes, it releases factors that increase activation and aggregation, excuse me. It also releases factors that are going to activate the clotting factors. The clotting factors are floating by in an inactive form. That's going to feed into the secondary hemostasis. But platelet activation is an initiating force to help activate clotting factors. So, the binding to von Willebrand factor activates the platelets. The activation of platelets causes further activation of platelets. In order to not make your picture just be a giant mesh of platelets on top of each other, what we just drew would be happening over and over and over again. Hundreds of platelets coming together, becoming activated, exposing 2B3A, tying together with fibrinogen. This positive feedback loop of platelet activation activating more platelet allows more and more platelets to be stacked on top of each other. When you have an aggregation of a bunch of platelets together, you have formed a platelet plug. This entire hole will be then filled with platelets strung together with very weak, flimsy fibrinogen, but they are held together and they're in place. If we go back to our slides, we can see the steps listed out here. First was platelet adhesion, when it became exposed to von Willebrand factor and it was able to bind to that agent. The binding of the receptor to von Willebrand factor allowed platelet activation. Platelet activation is when the platelet chain shape and exposed 2B3A releases fibrinogen, activates further platelet, and stimulates aggregation. So you could almost do kind of a positive feedback loop here, that with platelet activation, you get aggregation, which causes more activation, and around you go. So this is kind of a cartoon version of that, where you can see the internal elements and the resting platelet are kind of hidden from view, but when exposed to a wound, you get an activated platelet, and there is a domino effect here. It works to the advantage of preventing bleeding if you can have a positive feedback loop where one activated platelet causes more activated platelets. So the initial stimulus causes a change, which actually causes even more of the initial stimulus. Once you've had this domino effect, you end up with a whole bunch of activated platelets kind of strung together with fibrinogen. And this can fill in the gap in the vascular wall, and that is our platelet plug. Now, the platelet plug is very weak. And that's kind of meant to really be illustrated by that little single string of fibrinogen tying the 2B3A receptors to each other. They're held together, but this isn't going to hold for long. This is not a blood clot. It is just a quick collection of platelets kind of jammed into the hole to try to prevent the bleeding, to give enough time for the coagulation cascade to make a full, stable clot. So we've just drawn out the steps of primary hemostasis. The next step would be to induce secondary hemostasis. And the secondary hemostasis is going to be the formation of the clot. We're going to strengthen this initial platelet plug with a fibrin mesh and make a mature clot to stop the bleeding. So we'll leave it here for this part of the lecture, and we will pick up the coagulation cascade when we meet again in person on Wednesday. Thank you for your attention, and I hope you guys all have a great weekend. Take care.